Thank you for joining us for today's webinar. For those of you who have joined our previous webinars, welcome back. For those joining us for the first time, we are happy to have you. Today's lecture about COVID and Parkinson's disease is particularly timely since today marks the opening of the vaccination programs to the general public in Massachusetts. The fact that we are doing it as a webinar is also appropriate since this means that all of you are safe at home in preparation for today's snowstorm. Given our turnout of 250 people, we know this is a topic that is important to all of you. For the presentation, you will be muted throughout the lecture. If you have any questions, please feel free to type them into the Q&A box during the talk. We will also have time at the end of the lecture to discuss them with our speakers. As a reminder, please keep your questions focused to today's topic. Also, during the lecture, there will be several anonymous polls with questions for the audience. There is no obligation to answer the questions, but we would love your responses if you can share them with us. Also, at the end of the lecture, you will see some questions to give us feedback on today's session. We would really appreciate you filling this out as it helps us plan future lectures. Now I will pass it over to Dr. Hunk.
Thanks very much, Grace. So welcome to all of you for joining us for today's webinar. We know that this topic of COVID is one that's really basically occupied all of our lives for the last 10 months. And with some of the changes going on, we thought that this is a timely way to catch everybody up on what we know and don't know about COVID and how it pertains to people living with Parkinson's. Now, I will say this is the first time that I've ever given this lecture. I hope it's the last time I ever have to give this lecture. But anyway, this is an opportunity for us to share what we know. For today's webinar, it's really my pleasure to welcome my friend and colleague, Dr. Miriam Baron Barshak, to participate in this. Dr. Barshak is an assistant professor of medicine at Harvard Medical School, and she is a clinical infectious disease specialist at Mass General Hospital and Mass Eye and Ear Infirmary. Dr. Barshak knows much more about COVID than I will ever know as a neurologist, and so we thought that this would be a good opportunity to tag team and just get you up to date on what we know about COVID and the vaccine, and also to discuss some of the implications that it has neurologically and for people with Parkinson's disease. This is our plan for today. Dr. Barshak is going to lead off by giving an overview of the COVID-19 pandemic, what we know about the virus and about the disease that it's caused us. I will then talk about the effect of COVID-19 on Parkinson's disease and what we know from the limited studies that there are. And then I will pass it back off to Miriam, and she will go over what we know about the treatment and prevention of COVID-19. One of the things we will not discuss the distribution of the vaccine. We know that this is a very hot topic. Many of you have questions. This is something that is being orchestrated by each individual state. We have people on the webinar from different states as well. And we don't know much more about this than what you've seen in the paper or on the web. And so we're not going to get into a lot of detail about this. So just to start off, we thought we would launch a poll just to try to get a sense of the impact of the COVID pandemic on all of you. So Grace, if you want to launch that first poll, we want to get a sense of whether or not you have tested positive for COVID-19 during the pandemic, or if you've had a family member or friend who has tested positive for COVID-19. So just take a minute and just give us your responses. So Grace, if you can go ahead and share those results. I can't see them on my screen.
I can't share them either.
Okay, can you see the results?
Yes, I can see the results. So,
okay, why don't you share with us what the results are?
All right, so for the first question, have you tested positive for COVID-19 during the pandemic? 5% said yes, and 95% said no. Question 2, do you have a family member or friend who has tested positive for COVID-19? 48% said yes, and 52% said no.
Great, thanks. So it looks like about half of you have had somebody who you know who has tested positive. Fortunately, only a small percentage of you have tested positive. So I'm going to pass it off now to Dr. Barshak. She's going to tell you a little bit about what we know about COVID. And Miriam, you can take it from here.
Great. So I'm just going to unmute. I wanted to start by thanking the conference organizers for inviting me to give this talk. This is not the first time I've talked about any of these issues, but it's certainly the first time that I've spoken in this setting, and I appreciate the opportunity to be able to share this session today. Much of what I'm going to say overlaps with what you've probably seen and heard in the news and in the newspapers and online. There isn't a lot of kind of inside information in this pandemic, which is sort of an interesting aspect of living through this in real time, as I think the lay press probably has access to all the information that we do in the academic and other published literature, because the publication timeline in that literature is so long that it's often outdated when something that's changing as quickly as this. So just by way of introduction, I'm sure you all know that COVID-19 is currently causing what's called a global pandemic. That means that there are cases worldwide in large enough numbers that it's considered to be an epidemic in so many places that the word pandemic is used. And by global, I mean really all over the world. At one point, they were giving updated maps for countries that did and didn't have cases. There are pretty much no countries at this point that have never had any cases. At the moment, the current thought is that this is an infection that emerged originally in late 2019, initially in China, and has subsequently spread worldwide. You may know there in the news currently is a group from the World Health Organization, the WHO, that's currently doing a detailed investigation into the specifics about where and how the virus may have originated in China. And this is also being covered well in the general press, so you probably know about that as well. I wanted to just show a couple of maps that come from the CDC's website, if we could advance to the next slide. So if you look, you can see this sort of rough outline about how many cases there are in various places, and specifically in the last 7 days. This is updated every day by the CDC, so if you're curious about what the numbers look like, you can always go there. Just to highlight that the darker colors are places with more cases, so you can see here the United States, including Alaska, as well as much of Europe, are in the darker colors, and elsewhere in the world there are also large numbers of cases, but not quite as densely annotated as here. And the next map, I'm going to show you specifically data for the United States in more detail. And again, these are a number of cases since January 21st, and this is a map that was posted online on Saturday, so it's only very slightly out of date. You can see the total number of cases is 25 million plus, with a total of over 430,000 deaths. And again, in this map, the darker colors are places where there are more cases per 100,000 people. So in places where there's dense population, there may be more cases, but not per unit of population. And right now, the densest areas of population are in the American Southwest and in the Midwest still, but we definitely still have, unfortunately, large numbers of cases going on elsewhere, including in the Northeast. Next slide. So to round out the epidemiology, the COVID-19 transmission pathway, as I'm sure you know, is primarily by close contact, especially by being located less than 6 feet from somebody who may have the infection. The infection typically is transmitted most commonly by what are called respiratory droplets, which are relatively large, small particles that have sort of some fluid that holds them together along with the virus on them. These kinds of particles don't travel farther than a few feet, and so that's where the guidance for 6 feet apart comes from. Less commonly, though, there have been instances raising concern for what's called airborne transmission. And airborne transmission means smaller particles that can therefore linger in the air for longer periods of time and can spread over longer distances than the respiratory droplets. This concern about airborne transmission is what drives the current recommendations to be careful not only about distancing, but also about masking, including in areas where you may be more than 6 feet apart, but in a closed space. And so this is why in general, it's safer to be outside so that any of this possible airborne particles are less likely to reach you and more likely to be diluted with air particles that don't carry infection. In addition, it is thought that the virus can be transmitted less commonly through contact with contaminated surfaces rather than through the respiratory route. This brings about a lot of challenges in preventing the spread of infection, one of which, of course, is staying at least 6 feet apart from other people, including the fact that people may be infected without necessarily having symptoms, which is something I'm going to be talking about more later in the session. But even if you knew for sure that someone was sick, it's often difficult to stay more than 6 feet apart. And in addition, particularly in indoor environments, to be using masks to decrease the risk of inhaling some of these airborne type particles and sanitizing surfaces so as to not come in contact with contaminated surfaces from infected people. Next slide, please. So the word coronavirus itself, COVID, is a coronavirus infection. Coronavirus comes from the Latin for crown. And I've included in here a very commonly posted picture of a representation of what the virus may look like. And you'll notice that in this representation, it looks like sort of a gray ball with some red things that look sort of like push pins coming out of it. So these are proteins on the surface of the virus. And these are important both for the diagnostic testing that we do for COVID and also for the development of vaccines against COVID. And I'll be talking about those more a bit later. There are a lot of coronaviruses that we in medicine have known about for long periods of time. So the idea of a coronavirus is definitely not new. Many coronaviruses just cause the common cold, and these are things that we don't necessarily think so much about. But in the early 2000s, a virus called SARS, now CoV-1, emerged in East Asia and caused a lot of concern about the risk of a global pandemic, but ultimately did not turn into a global pandemic the way that COVID-19 has done for a couple of reasons. One of which is the fact that it was very unusual, if at all, noted for people to have this infection without symptoms. And so it was a lot easier to contain the infection by staying away from people who were sick. The other is that there were very aggressive infection control maneuvers put in place in the areas where the infection first emerged that limited its spread worldwide, and it was much easier to contain once it was recognized. A second coronavirus of concern emerged in 2012 called MERS, the Middle Eastern Respiratory Syndrome, and both of these infections luckily did not end up causing the amount of widespread infection that we're seeing now. But importantly, they inspired extensive scientific efforts to try to understand and prevent infection with coronaviruses. And that information that had been gained from research on these two other viruses has been applied toward research that has allowed faster understanding and vaccine development and treatment development for COVID-19 than we would have had otherwise. The virus that causes COVID-19 is referred to as SARS-CoV-2. And this virus, like other viruses, is composed of two main parts, one of which is the genetic material. In the case of the virus that causes COVID-19, that's RNA. And that is the target both for diagnostic testing and for vaccines. And the other important component of the virus is the proteins. And as I mentioned in this diagram, these are the targets both for diagnostic testing and for vaccines as well. Primarily, the most useful and used target is what's called the spike protein. That is the target of the vaccines that have been developed to date. Next slide, please. Illness with COVID-19, as you've probably heard through many sources of lay literature, is extremely variable. Many people with COVID-19 have no symptoms at all. Many other people with COVID-19 have relatively mild symptoms, but unfortunately, a small subset of people with COVID-19 end up developing symptoms that are severe and symptoms that may require even ICU level of care and ultimately progress to being a fatal infection. Fortunately, the majority of infections are mild. About 80% in multiple studies have been patients with only mild infection. And about 20% are patients that have symptoms that are severe enough to require some kind of medical evaluation in a hospital, of which most end up being non-critical. And about 5% of people with COVID-19 may develop critical illness that requires ICU level of care. Fortunately, many of those patients survive, and not all of the 5% that end up in the ICU wind up dying from infection. But given the number of cases of COVID that there are worldwide right now, even if less than 1% of patients have illness that's fatal, that winds up being a lot of deaths that we hope to be able to prevent. Next slide, please. So the typical time course for COVID-19 infection. The first week, so starting 2 to 14 days after exposure is when symptoms may begin. Most commonly, people who've had an exposure to someone with COVID infection will develop their symptoms by day 4 to 5, assuming that they're going to develop symptoms. The vast majority, more than 97%, will have symptoms by day 12. And by symptoms, what I mean are symptoms that are often relatively mild. So runny nose, cough that's usually a dry cough, low-grade fevers or even high-grade fevers or chills, fatigue, muscle or body aches, headache, new loss of taste or loss of smell, which is a distinguishing feature of COVID-19 compared to a lot of other respiratory viruses out there, sore throat, nausea or vomiting, and sometimes diarrhea. Typically, the shortness of breath develops later in infection, usually not during the first week, but sometimes, particularly in people who may have lung problems to begin with, the shortness of breath may start earlier. By week 2, because most infections are mild, most patients are recovering. Unfortunately, however, there are patients who are not recovering, and these patients are typically the ones that are developing worsening shortness of breath around days 7 through 10. People who end up needing an ICU admission typically end up declaring that between days 8 and 12. So in the middle of that second week of illness is when things can get much worse. And the complications from COVID-19 can include most organs of the body. People can develop a secondary bacterial pneumonia or lung infection after the initial viral infection from COVID, and can also develop damage to multiple other organs outside of the lungs, including their kidneys, their heart, blood clots in various organs that can include the brain, leading to neurologic symptoms that Dr. Hun will be talking about later, and others. In the recovery phase, people can have lingering cough, fatigue, and loss of taste or smell that can linger for weeks afterwards. Fortunately, most people will ultimately recover, but it's quite variable how long these symptoms can last. In addition, many of the more recent case series that have looked at patients far out from their COVID-19 infection have documented well that patients can have lingering psychiatric symptoms, including anxiety and PTSD, post-traumatic stress disorder, both about their illness and about the medical treatments that they needed during the course of their infection. Next slide, please.
So as you've heard from Dr. Barshak, the range of symptoms that a person can get medically from COVID-19 range from being very mild to very severe. And this is the case too for neurological symptoms related to COVID-19. On the right side, you can see a range of some of the neurological manifestations of COVID-19. Some of the mild symptoms are hyposmia or hypogeusia. This means a change in smell or taste. Oftentimes people may get a mild headache or dizziness early on, but this can progress to much more severe symptoms, double vision, problems with walking, Guillain-Barré syndrome, which is a rare condition that affects the nerves. Because of some of the clotting issues that can be associated with COVID-19, there's a higher risk of a patient developing a stroke within the context of COVID-19 infection. And people can also, in rare cases, develop a severe inflammatory response in the brain that causes destructive brain injury, what we call a necrotizing encephalopathy. On the left, you see some of the possible mechanisms by which COVID-19 can induce changes in the brain. When you get a COVID-19 infection, it causes widespread inflammation in your body that affects not only the systemic organs, but can also involve the brain. Many people who have severe COVID-19 infection can get altered regulation of blood pressure. And as we all unfortunately know, respiratory function is severely affected in more advanced cases of COVID-19. What this can do is it can result in decreased oxygen levels in the body, and that can have some direct effects on the brain, causing changes related to low blood flow and decreased oxygen delivery to the brain. As I mentioned, there's this also this complication of developing increased blood clots. And this is well described now in COVID infection. It can affect the legs, it can infect the lungs. And when these blood clots either spread or develop in the brain, they can cause stroke. There's also interest in terms of more direct effects of COVID-19 infection on the brain and on the nervous system. And that's because the virus itself can infect certain cells within the brain. And I'll tell you a little bit more about that. In rare cases, you can actually detect the SARS-CoV-2 virus in the cerebral spinal fluid, the fluid that bathes the brain and the spinal cord. So we know that while this is not something that many patients experience, in more advanced cases, the viral infection can spread directly into the nervous system and affect brain cells. Now, I'm going to present some of the rest of the talk based on trying to address a number of frequently asked questions. These are questions that many patients have posed to me in the clinic or through various messages. And also, I think that there are a lot of questions that I've heard from the Parkinson's community about concerns of theirs. So the first question we're going to discuss is there any relationship between COVID-19 and Parkinson's? Can COVID-19 actually cause Parkinson's? Now, there is precedence for viral infection causing a Parkinsonian syndrome. In 1918, when the Spanish flu hit, there were a large number of patients who developed a Parkinsonian syndrome. It was not typical Parkinson's disease, but it shared properties with Parkinsonism in the sense that people were very stiff, very slow. They had changes in voluntary movement, much the same as a person with Parkinson's disease might have. And so this was called post-encephalitic Parkinsonism. And for those of you who have ever seen the movie Awakenings or read the book, this was the description of a large group of people who, after the flu epidemic in 1918, developed symptoms that prevented them from living independently on their own. And this was actually the way that we learned that levodopa could treat Parkinsonian symptoms, because patients who had post-encephalitic Parkinsonism, when given levodopa, miraculously woke up. Their movements started improving, and that was because they had a condition that responded to dopamine replacement. Now, the 1918 epidemic was caused by the H1N1 virus, which is not a coronavirus. But we also know from animal models that a different virus, H5N1, is another influenza virus. You can actually use that to create changes in the brain that resemble Parkinson's disease. And so I think both of these pieces of evidence suggest that there can be a relationship between viral infection and Parkinsonism, although for the majority of people, that's not the case. Now, what do we know about the way that SARS-CoV-2 affects the brain? So SARS-CoV-2 can enter cells in the body through particular receptors called the ACE2 or angiotensin converting enzyme 2 receptor. In addition to organs in the body, there are parts of the brain that express these ACE2 receptors. Some of them are shown here. For instance, the substantia nigra, the part of the brain that's often involved in Parkinson's disease, expresses H2 receptors that potentially provide a portal where the virus can infect. Another part of the brain that's affected in Parkinson's disease, called the striatum, similarly expresses ACE2 receptors, as does the olfactory bulb, the part of the brain that houses the neurons that are responsible for smell. So there's a lot of interest about maybe the early loss of smell that people with COVID-19 experience that's different than your run-of-the-mill viral infection, is because of this direct invasion of the SARS-CoV-2 into the olfactory epithelium. So in addition to the possibility that SARS-CoV-2 can affect parts of the brain that are relevant for Parkinsonism. We also know that alpha-synuclein can be upregulated by certain viral infections. Now, many of you know that alpha-synuclein is a protein that is very core to the development of Parkinson's disease. When people with Parkinson's disease get abnormal alpha-synuclein deposits in the brain and other parts of the nervous system, that's thought to be what causes your symptoms to develop. And so there are a number of different types of viral infections, including West Nile virus, where alpha-synuclein has been shown to be upregulated. So there's an interesting hypothesis that if COVID-19 could also upregulate alpha-synuclein, and we don't know that that's the case, but if it were, potentially that could cause some changes that might further contribute to a Parkinson's cascade. One thing that we do know about SARS-CoV-2 is that it activates an exaggerated immune response, and neuroinflammation is thought to play a role in many neurodegenerative conditions, including Parkinson's disease. So there's a question or a concern about how this exaggerated inflammatory response that's precipitated by COVID-2, what impact that could have on changes of Parkinson's in the brain. Now, you already heard from Dr. Barshak that anosmia, loss of smell, or GI symptoms are very common early in COVID infection. It's interesting that many people who eventually will develop Parkinson's may notice some of these changes even before they develop tremor or other Parkinsonian symptoms. And so there's this overlap between the symptoms of early COVID infection and what we call the prodromal phases of Parkinson's disease, and raises some concerns and some questions about whether or not with this very large group of people who are getting COVID-19 infection, what implication that might have for the development of Parkinson's in the future. Now, to date, there have been 3 cases of Parkinsonism that have been newly reported in the setting of COVID-19 infection. Whether or not these patients were eventually going to develop Parkinson's and the COVID-19 was either coincidental or just brought that out a little bit earlier, or whether or not the Parkinsonism was directly related to the infection, we don't know. One thing that's obviously of concern is that the ages of these 3 patients were 35 to 58, which is on the younger side of developing Parkinson's disease. And I think only time will tell how this COVID pandemic affects the number of people living with Parkinson's in the future. So the next question is, what is the risk of getting infected from COVID-19 if you have Parkinson's disease? Now, let me preface some of the slides that I'm going to be showing you in the next few minutes, that these are based on relatively small case studies. So because COVID-19 is such a new pandemic, we don't have as much information as we like. And hopefully over the coming months or years, we will know much more. So I'm going to present the data that we have and just recognize that this, with the caveat that we don't have that much information. So there was an early case control study coming out of Italy where the pandemic hit very early in Europe, where 1,400 or 1,500 Parkinson's patients and 1,200 family members that were followed in a movement disorders clinic in Italy were questioned about whether or not they developed COVID infection. Now remember that this was early in the pandemic, so not all of these were necessarily confirmed with positive COVID testing. This is basically the development of symptoms that look like COVID. In this early case controlled study, there was no difference between the percentage of people who had Parkinson's developing COVID and those who, their control family members. So roughly in this particular study, about 7.5% of the people who were surveyed developed Parkinson's disease. Now there's a lot of potential confounders here. So for instance, maybe the patients with Parkinson's disease didn't go out as much. And so the fact that they had a similar percentage of infection might not necessarily reflect a similar susceptibility to infection, but maybe their particular habits or behaviors lowered their percentage to something that was comparable to the control. If you look at the patients with Parkinson's disease who were infected, there were a number of risk factors that increased the likelihood of infection. Obesity, COPD, chronic obstructive pulmonary disease. These are probably not that surprising. One of the things that was a little bit surprising is that this study showed that Parkinson's patients who were younger actually had a higher risk of being infected than those that were older. And again, this again raises the question of whether or not there was some difference in behavior or the risk of exposure that might have changed their likelihood of getting infection. There was also an interesting finding that more unaffected patients were taking vitamin D supplements. Now, we just don't have enough data about this yet. So whether or not vitamin D protects at all against COVID infection, we just don't know. This was just something that came out of this control study. So what happens if a person with Parkinson's disease does get an infection? How does that change their outcome? So this first set of data is from the study that I just told you, about 1,500 Parkinson's patients with 1,200 controls. In this particular study, the percentage of people who died who had COVID was quite comparable. So again, look at the numbers, they're small. Only 105 people with Parkinson's disease and 92 control patients were sampled here. And the percentage of people who died because of COVID was quite comparable. There was another case series that was done in Europe and in Iran that showed a higher percentage of people dying with who had Parkinson's dying from their COVID. About 20% of the people in their particular study died. But again, the numbers were small. One of the things that was helpful from this study is that there was a higher risk of having a poor outcome if a person with Parkinson's disease either had coexisting dementia or hypertension, and there was an association between the outcome and the duration, the amount of time a person had Parkinson's disease. So a graph from that particular report is shown here on the right. It's separated into the amount of time that a person has had Parkinson's disease, less than 5 years, 6 to 10 years, 11 to 15 years, and more than 15 years. The black bars refer to the percentage who died, and the gray bars reflect those people who had those comorbidities of either dementia or hypertension. And so in this particular study, in each case, there was roughly 1.5 to 2-fold increase of having a poor outcome if you had one of those two comorbidities. There was another more recent study looking at 696 patients with Parkinson's disease, 184 with Parkinsonism, meaning a form of Parkinsonism that was distinct from typical Parkinson's disease, and a large number of controls. Now, in this particular study, the numbers were much smaller. This was probably done a little bit later in the pandemic, and whether or not this had to do with increased early diagnosis or recognition of those symptoms, it's hard to know. But in this particular study, the percentage of patients, this is hospitalized now, so it's a different metric, but the percentage of patients that were hospitalized with Parkinson's disease compared to control was roughly the same. People who had other forms of Parkinsonism had a higher rate of being hospitalized. And this perhaps might reflect the stage of disease. Many people who have other forms of Parkinsonism may not respond as well to Parkinson's medications. And so they may have a higher degree of debilitation to start out with. This is a larger study that has just been published, looking at a database review, mostly from the United States. Now, this particular study has the limitation that it was basically done by surveying insurance databases and looking for the number of people who developed COVID infection and what their outcomes were. So this looked at more than 50 million patients, and it identified about 50,000 adult patients that were infected with COVID and about 700 who had Parkinson's. And so they compared what the outcomes were for people who did not have Parkinson's to those who did. It looks like there's a significantly higher risk of having a poor outcome, of dying if you have Parkinson's compared to those who don't. Now, the important thing to recognize is that the Parkinson's population were an older group. There tend to be more men, And there was also a difference in terms of the racial breakdown between those with Parkinson's and those without. And so if you use some statistics and try and remove as many of those confounders as you can, it suggested that the odds ratio of having a poor outcome for those with Parkinson's disease was 1.27. In other words, there was a 27% higher risk of dying because of COVID if you had Parkinson's compared to if you didn't. And this is a graph showing the breakdown over age. So below the age of 65, the difference is not very great, and the difference spreads out in an older group of patients with Parkinson's disease. And so the way I take this data is that we just don't know yet for sure what is the relative relation between COVID infection and Parkinson's disease. Perhaps it does increase the risk of a poor outcome. The data are not in about whether or not there's any higher risk of infection. So what I want to do now is I want to launch another poll and try to get a sense from all of you about what impact COVID-19 has had on your particular symptoms, whether or not you have had infection, which is just a small group of you, or when you haven't. So Grace, maybe you can launch that next poll. So there are 3 questions here, so you can scroll down to make sure that you see all of them, and we'll give you a minute to answer those questions. Grace, can you go ahead and share those results with us? Okay, so I'm not able to, oh, there we go. All right. So as far as motor symptoms go, about 50% said they were unchanged, 40% said they were slightly worse. As far as mood and anxiety, the majority of people have had, feel that that's been stable. And again, the majority of people have found that their sleep is unchanged. There is a percentage where those symptoms were there before, but now they're slightly worse. So let me show you what the data shows. So there was a study that was published from Italy, and you will see that the numbers are extremely small. So again, we have to take what we know with the caveat that this does not sample very many patients. So in this particular study, they compared 12 patients who tested positive for COVID to 36 negative controls. Of those 12 patients, 3 did not have any symptoms at all. 8 had moderate disease. 1 was hospitalized because of pneumonia. The result was that many people found that their motor symptoms and their function on daily activities was worse in the context of their COVID infection. In fact, a third of the patients actually required an increase in the amount of Parkinson's medicines, which typically we don't need to do over a short time frame of a few weeks. Now, whether or not that was related to worsening of the Parkinson's symptoms because of his systemic inflammatory response, or whether or not that was because some of the GI symptoms affected the ability for a person to absorb the medication, we just don't know. It was also shown in this study that many of the non-motor symptoms of Parkinson's, including fatigue, mood, urinary function, and cognitive function, were worse in those patients who had COVID infection compared to those who weren't. There have been other surveys that were done which show similar results, that in the context of COVID infection, people with Parkinson's may experience a change in their motor symptoms. They may have more motor fluctuation, hallucinations, anxiety, mood, or sleep issues than those patients who do not have COVID infection. Now, this is a larger study that was a online survey that was done by the Michael J. Fox Foundation. They have a group of about 9,500 patients who are enrolled into this Fox Insight program. And they sent out a survey and asked them how their symptoms had changed. So there were 5,500 Parkinson's patients, about 1,500 family controls who were largely family members, and only a small percentage of them had COVID infection. Now, what you'll see on the right is how people responded, whether or not they developed new symptoms or worsening symptoms of various types in the context of COVID infection. And what you see is for the 50 some odd patients who had COVID infection, many of them noticed changes in some of their symptoms, whether it was balance, problems eating or appetite, falling, slowness of movement, their bradykinesia, their stiffness. Many people noticed either new or worsening symptoms, motor symptoms, and they also noticed a change or an increase in some of the non-motor symptoms. Now, what's interesting is here on the right, you see what was the change in Parkinson's symptoms in patients who did not have COVID infection. And so the numbers are smaller, so roughly about half those who actually had COVID infection, but you still see that many people noticed a change in their Parkinson's symptoms in the context of the pandemic. Now, this survey was sent out very early in the pandemic. It was sent out in the spring. And so how these data would change if people were polled now, I think is an interesting question. This is a telephone survey looking at the effect of Parkinson's on psychiatric symptoms in PD. Anxiety and depression or apathy are not at all uncommon in people living with Parkinson's disease. And so for this particular study, out of the 134 patients that were surveyed, 100 of them reported some degree of anxiety or depression even prior to the pandemic. Of those, about a quarter found that their symptoms were worse. This is a demonstration of some of those changes, and the ones that are most noticeable here are changes in mood and changes in sleep. And those patients who were more likely to find that their symptoms were worse, it was associated with younger Parkinson's patients, women more than men, and those people who noticed or felt that their Parkinson's symptoms subjectively worsened also reported an increase in some of these neuropsychiatric symptoms. The pandemic has also had significant effects on people's sleep patterns. So there are two small studies looking at changes of the COVID infection and the pandemic on sleep. So in one case study that was published out of Wuhan, China, there were 119 Parkinson's patients who were surveyed and 170 controls. About 70% of Parkinson's patients developed a sleep disturbance. Now, sleep problems in Parkinson's are not unusual, but this is higher than we would expect for the general population of Parkinson's patients. There was another cross-sectional study published earlier this year from India of 832 patients with Parkinson's disease. And about a third of them had a sleep disturbance, with about a quarter of those finding that either it was new or got worse. And so again, insomnia was a major issue for people living with Parkinson's disease within the context of the pandemic. And the restless leg symptoms and REM sleep behavior disorder, that tendency to act out your dreams, could also get worse within that context. So we're going to launch one more poll now and ask what effect Parkinson's has had on your physical activity. Because I think in addition to changes on Parkinson's symptoms themselves, Parkinson's has affected the way all of us live. Your ability to be able to exercise, get out, walk has changed. And so, Grace, if you can launch that last poll. We're just curious to find how your level of physical activity has changed since the start of the pandemic. Why don't we go take a look at that response now? Okay, so it's interesting. About a quarter of you have noticed an increase in your level of activity, and that's great. You know, I think that it's very, very hard to stay active these days, and I think that maybe because you have a change in your schedule, you have more time at home, you have other fewer things that you have to do when you go out. There's a quarter of you that are more active. Not surprisingly, more of you have been less active. I think it looks like a third of the group is slightly less active and about a quarter is significantly less active. So what do we know about changes in physical activity? So again, this is a small survey. This is looking at 75 patients, and look again at the dates. This is very early on in the pandemic in Italy. These patients did not have COVID-19 infection. So here we are looking at what people reported as a consequence of the pandemic, independent of having any infection. It was a fairly typical group of Parkinson's patients, with the mean age being around 60 and the age of onset being around 55. About 60% of the people who were surveyed here felt that their overall condition was worse. And the main indicators of their overall condition being worse was related to the intensity of their physical activity, as well as the way that they felt their symptoms had changed, either physical symptoms or depression. For those who were participating in physical therapy, up to 80% had to interrupt treatment. Now, for those of you who are getting any kind of physical therapy here in March and April, you can definitely understand why that's happened. Things have changed a little bit for the better since then, but still, people's habits are not the same as they were before March of 2020. Now, what's interesting is that 63% of the people surveyed here use technology-based, this meant technology-based training. And more of the people who used it were women compared to men, and almost 50% used some kind of technology-based training for the first time. And so with that, I'm just going to bring up our Mass General Parkinson's virtual exercise program again. Some of you may be participating. For those of you who aren't, this is just another another way that you can use to stay active. So this is led by Laura Plummer, who is an assistant professor of physical therapy at the MGH Institutes of Health Professions, and she's our Center of Excellence physical therapist. This started in April, shortly after the pandemic. It is held live on Zoom on Tuesdays and Fridays, and we would love to have any of you who are interested join. And so if you are looking for more information, you can contact Grace at that email, and she'll send you the link. So I'm going to shift it back now to Dr. Barshak, and she's going to talk to you a little bit about what we know about COVID treatment and prevention.
Thank you. I'm just watching the time. I know there are a lot of questions about vaccines, so I'm going to give a little bit shorter shrift of antiviral treatments to be able to spend more time on that. So when we think about COVID-19 and treatments, we think about the infection in two phases. There's the early phase when there's likely to be quite a lot of virus around. And then there's the later phase when it seems, based on our clinical evaluation of patients and on the effectiveness of some of the treatments that have been tried, that in the later phase, the primary driver of the symptoms and the problems seems to be more related to the immune responses that are generated by infection rather than to the virus itself. And so you'll see on my slide that the early phase treatments are mostly antiviral. These are things like giving people antibodies that they may not have. So these are immune responses against the virus. Those kinds of antibodies are also found in convalescent plasma, for which there's mixed data about how effective they are. And then antiviral medications, and I'm not going to spend a lot of time on those today. In the later phases, as I mentioned, the major breakthrough earlier in the pandemic was the recognition that steroids, specifically dexamethasone, but other steroids as well, can be very beneficial for quieting down some of those immune responses that are causing harm. And there has been some interest in other immune modulators for treatment in the later phase that is still ongoing. And I just see there's a note in the chat saying that my sound is cutting in and out. I hope this is better, but please, if there's ongoing problems, let me know. Next slide, please. So this brings us to prevention. As we say, an ounce of prevention is worth many pounds of cure in the case of COVID-19. And again, to emphasize that there's a lot that we're able to do from the behavior standpoint to decrease the risk of getting infection. I'm sure you've all heard a lot about masking and distancing and hand hygiene. I wanted to add to that some emphasis on isolating from other people if you're feeling unwell. So, don't go ride in an Uber if you're feeling sick, or do other things that might put you in contact with other people. and then quarantining, which means, again, staying away from other people if you're infected or exposed. And the specifics about how long to be in quarantine and specifically which symptoms are important for thinking about are sort of beyond the level of detail of this talk, but I'm happy to answer more questions afterwards, because as I mentioned, I wanted to focus on vaccines. So next slide, please. So COVID-19 vaccines were developed in an incredibly record amount of time compared to other vaccines that have been developed for other infections. The main goals of vaccines are three. One is to protect the individual who's received the vaccine. One is hopefully to prevent the spread of infection. And the last is to develop what's called herd immunity, which means that if enough people in a given area are immune, then there aren't people that are susceptible to getting infection, and therefore the infection eventually has nowhere to go and hopefully dies out. I've included in this slide a map from the CDC's website indicating how much vaccine has been distributed, again, per 100,000 people. And you can see in Massachusetts here, we're doing okay, but there are some states who've been doing better. As Dr. Hung mentioned, today is an important day in the time course of the pandemic here in Massachusetts, as the first vaccines are being offered to people who don't fall into the category of healthcare workers or nursing home residents. And today is the first day that the state has authorized vaccine centers to start giving out vaccine to patients who are age 75 and above. I think our next, before the next slide, I think we had another poll that we wanted to post. Great. So I'm interested to hear about people who are, what your thoughts are about vaccine. First question is whether you're planning to get vaccinated. And the second question is, if you did get vaccinated, what kinds of side effects, symptoms you may have had. And then the third question is whether your side effects were mild, moderate, or severe. And the last question is, if you're undecided about the vaccine, what the reasons are. So I'm going to give you a few minutes to put in answers for that before I move on. Grace, whenever you feel like you have enough of the answers, please feel free to post the result.
I don't know what happened, but they just started answering the questions now. Probably took time for them to view it. So just about 6 people have just logged onto the poll. So maybe we'll just give them 30 seconds.
There's some comments in the chat that say that people aren't able to submit if they say they haven't yet gotten the vaccine. You should feel free to go ahead and put your answers in the chat if you're not able to answer in the survey.
Yeah. Okay. All right, I'll just end the survey, the poll now.
Great. So for the people who've answered in the chat, it looks like mostly people who are planning on getting vaccinated or who have gotten the vaccine and have some mild symptoms. And the poll answers like many people have gotten vaccinated, more than half, or at least of the people who were able to answer the question. And of the people who got vaccinated, more than half have had arm pain or swelling, which is pretty consistent with what's been reported in the studies, although there is a significant third of people who said they had no side effect. And I note that only, unfortunately, 9 people were able to answer, but a worsening of Parkinson's symptoms hasn't been reported among the survey answerers in the poll. And then as far as the other questions, the side effects, the vast majority, 8 of the 9 people with side effects said that they were mild. And there's nobody who was able to answer the part about undecided. There's a couple of people who've written in the chat saying that there's not enough data to support getting it. So I'm hoping that some of the questions that are coming up both in
Miriam, we've lost your audio.
Uh-oh. How about now? Can you hear me?
Thank you.
Are you able to hear me now?
Yes.
Okay. Let's move to the next slide, please. Great. So I wanted to review a little bit about vaccine strategies. So you'll be hearing in the news, if you haven't already, about a few different types of vaccines, and just to help people to understand what those terms mean. So mRNA is genetic material that instructs our cells to make the spike protein for this vaccine, which then triggers our immune system to mount a response to the spike protein, so that our immune systems will be primed and ready to attack COVID-19 if we get exposed to the real virus. The DNA vaccines, which are made, the ones that are currently being reported on, are made by AstraZeneca, Johnson & Johnson, and also Novavax, since I made this slide. These are adenovirus-based vaccines that include a gene for making the spike protein. These are easier to store than the mRNA, so they don't require the super cold kinds of freezers, and therefore they're less expensive and more sort of straightforward as far as distributing broadly, both within the United States and in places that may have less resources for the conditions that are required for the more fastidious vaccines. Importantly, I wanted to highlight that the virus does not replicate. It's not a live vaccine. It's just a tool for getting the genetic material into the cells so that the cells will produce the protein that then generates the immune response. There are certainly other vaccine strategies that are in process, including some strategies where the protein itself is being injected to generate that immune response. But I want to emphasize that none of the vaccines that are being used or evaluated in the United States are live vaccines. And therefore that none of them are a particular concern for causing problems with introducing infection in people whose immune systems may not work well. And also that none of the vaccines that are being used or evaluated in the United States at this time interact with our DNA. So they don't cause genetic changes in the person who's receiving them. Next slide, please. This is a schematic that I'm hoping will help to illustrate the sort of principles involved and how these vaccines are developed. So I want to focus attention on the top panel here. In our bodies, human DNA is converted to something called mRNA, which is then translated into the proteins. When we make vaccines that use this pathway, for example, the adenovirus vaccine that is used in the Johnson & Johnson vaccine, the adenoviruses actually include the DNA, which is then translated into the spike mRNA and then translated into the spike protein. In contrast, the earlier vaccines that were released in the US, the Pfizer and the Moderna vaccines, start here. They start with introducing the actual mRNA, so there's one less step in generating the protein. But again, this comes with the downsides of having more difficulty in distributing these vaccines because of the conditions that are required. It makes them more expensive, and they also need to be given in 2 doses in contrast to some of the DNA vaccines. Next slide, please. So the common vaccine side effects are the ones that I included in the poll, which I'm sorry was a frustrating experience for many of you. The common symptoms are arm soreness, which is also referred to as an injection site reaction, fatigue, headache, muscle pain, chills, and these symptoms are somewhat more common overall after the second dose compared to the first dose. A rare side effect that I wanted to highlight, because it has been understandably in the news a lot, is something called anaphylaxis. This is an allergic reaction to the vaccine. Anaphylaxis has been reported in somewhere between 2 and 11.5 patients per million doses that have been given of the current mRNA vaccines, those made by Pfizer and Moderna. These types of reactions typically develop within 15 minutes of administration. And so for this reason, all of the places that are administering vaccines are supposed to be monitoring you there live for at least 15 minutes after you receive the vaccine. Reassuringly, in some cases, almost all of the patients who developed anaphylaxis have been in patients with prior severe allergic reactions to medications or vaccines. And so while I'm sure this isn't reassuring for people who've had these kinds of reactions, it's reassuring in the sense that we can relatively easily identify people who are at high risk for this problem by asking about their history of medication or vaccine reactions, and use more cautious monitoring in people who've had these kinds of reactions before, including consulting with an allergy specialist for the appropriate protocol to use if these patients are going to be getting vaccine. It's thought at this point that these types of allergic reactions are triggered by one of the vaccine ingredients that's called PEG, or polyethylene glycol. This is a component of the mRNA vaccine technology that's used to stabilize the mRNA. This is not an ingredient that is included in the DNA vaccines that are being used at this time. Importantly, there have been no deaths after vaccines from anaphylaxis or anything else. And so this also reassuringly suggests that these are very safe vaccines. Next slide, please. This is just an example of a table that was posted late Friday with the data from the AstraZeneca Oxford vaccine that had just come out, with a comparison about the side effect profiles compared to the mRNA vaccine that was made by Pfizer BioNTech. And you can see that the names of the side effects are pretty similar. Every category has percentages next to it. And in general, the rates of side effects, I would say, are quite comparable. There's a little bit lower risk of arm pain from the AstraZeneca vaccine than from the Pfizer one, but this is offset by a higher rate of joint pains for the AstraZeneca vaccine compared to the prior one. And overall, I would say we think of the rates of side effects of these vaccines as probably being similar. Importantly, in most cases, if you're getting vaccine, it's unlikely that you're going to have, at least at this point, an opportunity to choose which vaccine you want, because the amount of vaccine available relative to the number of people who are interested and in need of getting it is relatively small. Next slide, please. So vaccine effectiveness, this is a really important point. When we talk about vaccine effectiveness, it's important to know how effectiveness is defined. In the vaccine studies that have been reported to date, effectiveness is being defined as cases of moderate to severe COVID infection, not any COVID infection. So what that means is that when the literature says that 95% efficacy has been described for the mRNA vaccines, that means more than 95% of cases of moderate to severe COVID have been prevented. Moderate means patients who've needed to be hospitalized. Severe means patients who've needed to be in an ICU or have died from COVID. And I will add that no patients who've received any of these vaccines have died from COVID. They've been very effective so far, at least, at preventing severe illness and death. The rates that have been published for the mRNA vaccines, as I've listed here, include 95% or so for the Pfizer and Moderna mRNA vaccines, and 60 to 70% for the AstraZeneca Oxford vaccine that was just authorized by the EU last Friday. I wanted to highlight that most of the participants in these trials were aged between 18 and 55, so we're still waiting for better data on that AstraZeneca Oxford vaccine on the older vaccine participants. The Johnson & Johnson vaccine, for which data was also released this weekend, came out at a rate of 72%, again, for preventing moderate to severe illness. But you will see all over the news the fact that these rates looked worse for patients in South Africa, where there are new variants of the virus that have emerged, that have mutations, that have raised concerns about the efficacy of all of these vaccines. I wanted to add as a commentary that the studies on the mRNA vaccines were done earlier in the year, before these viral mutants that were noticed in South Africa were emergent, and in conditions where the numbers of cases in the community and risks for infection were somewhat lower overall than they are now. So it's hard really to directly compare these numbers. The studies were not designed the same way under the same conditions with the same patients, because that would be impossible to do. And I would say from people in the field in infectious disease and in public health, the rates of efficacy for all of these vaccines are really good. They're all better than the risks of getting severe COVID. And we're definitely encouraging any and everyone, including whether you've had COVID or not before, to get vaccinated, because the risks of potentially getting infected with a mutant version of vaccine that you don't have immunity to, even if you've had infection before, are certainly there. In the long term, we don't know much about the vaccine effectiveness because these are new vaccines, but this is definitely an area that's under active investigation. And certainly there are concerns about how long the immunity may last, whether there may be mutations in the viruses in our communities that may emerge that the vaccine is no longer as effective for. But I would say that at this particular moment in time, these are both hypothetical concerns and concerns that can potentially be addressed with booster vaccines that all of these companies are currently working on developing. This is an area of fast moving change, and anything that I tell you today may well be updated with new information tomorrow, but this is where we're at as of today. Next slide. So again, I want to emphasize the importance of both behaviors and also vaccines in preventing COVID-19. I want to also emphasize that getting vaccinated does not yet equal a good reason to stop doing all of the behaviors that prevent people from getting COVID-19. Unfortunately, we're not yet at herd immunity, so there certainly are still vulnerable people in our communities, even if you yourself are immune. It's important to think about the rest of public health for us. But in addition, there aren't data yet that tell us how well the vaccines prevent against transmission. So again, these studies were developed to look at moderate to severe cases. They didn't look for people who may be asymptomatic, but actually carry the virus and can cause infection to other people. So what I wanted to leave you with today is the message about the importance of continuing these behaviors, certainly at the moment, and the CDC will be actively weighing in about when and if they feel like it's safe for us to relax some of these strategies. And to encourage people to get vaccine, even if they've had infection. The current thought about having had infection is that it probably gives you good immunity at least for about 90 days after your infection, 3 months or so. And so while it is still recommended to get vaccine, it isn't quite as urgent, and it may be worth waiting on the vaccine until some of the people who are really not at all immune have had a chance to get their dose if you've had infection yourself. Next slide, please. I wanted to leave you with the message about the fact that these vaccines will not give you COVID-19. I didn't see anybody bringing up this concern in the chat, but this has definitely been a generalized concern among patients that I've received questions from, and certainly in the general public. I know there's a lot of anxiety about this, and I want to assure you that that's not a risk of these vaccines. That's the end of my prepared comments. I'm going to switch over to Dr. Hung.
I'm just going to close with a couple of words about the phases of vaccination, because this has been very hard to understand. And I just want to give you a little bit of thought about how a diagnosis of Parkinson's might play into this. As many of you know, we are starting, or the state is starting phase 2 vaccination today with individuals over the age of 75 being eligible. The next phase, phase 2B, are those people over the age of 65 and those with 2 or more comorbidities. Now, what a comorbidity is, I think, has been a difficult question to understand. And so if you go to the CDC website and look for the list of comorbidities, these are the ones that are currently listed. I went to the Mass Public Health website over the weekend and found that if you try and sign up for a vaccination, they will ask you specifically for one of these items. Now, what you will not see here is you don't see Parkinson's disease. If you go to the CDC website, there is a list of those conditions that are associated with possibly increased risk. And under that, you will see neurological conditions such as dementia. If you click on that, you will come to this page, and they will talk about dementia, and they will talk about ALS or Lou Gehrig's disease, but there is no mention of Parkinson's disease. And so at this point, Parkinson's disease is not considered to be a comorbidity when it comes to signing up for the vaccine. So those of you who are over the age of 75 in Massachusetts can sign up now. Those who are 65 or older will be part of the next phase. And if you do have a comorbidity, you can be part of that phase also. But if you are below the age of 65 and you're otherwise in good health apart from your Parkinson's disease, based on the current guidelines, you wouldn't qualify until a later phase. So this is just a summary. The important things to know: there is no known interaction between the vaccine and Parkinson's disease. There is no known interaction between the vaccine and any of the Parkinson's disease medications. So you don't need to worry if you're on levodopa or another medication that the vaccine and the medications will interact. And Michael Oken, who is the director of the Parkinson's Foundation, the national medical director, he said, if you have Parkinson's disease, you should get the COVID-19 vaccine. I would agree. I would really encourage everybody to get the vaccine, whether you have Parkinson's or not. But especially for those of you who are on this call, if you have Parkinson's disease, there may be a risk of a more serious outcome. And regardless of that, the importance of the vaccine can't be understated, both for your own health and for public health reasons. So with that, we'll close this. Thank you for your attention. I know we've gone a little bit over time, but I think that the number of you who have joined onto this webinar tells us how important this topic is to you. So we will now take a few questions, okay?